I'm going to abbreviate my talk a little bit. I took my assignment very literally about talking about why are we so polarized. I figured, well, you know, we're surgeons. We all are rarely in doubt, even if by the facts. My first two slides that I eliminated, and I did not conspire with the speakers, I pulled references with and BEMA versus SEMA. And what I discovered at the 90 to 95% level, I pulled exactly the same references that you saw given to you today. Just emphasizing my first point here, that we all have access to the same information, but we draw different conclusions. How many of you are planning to change your practice as a consequence of the brilliant arguments that we... Yeah, figured as much. So now, you know, we have access to the information. In general, we understand the hierarchy of evidence. The details and often the applicability are generally in the fine print. That was pointed out well today. Independent critique of studies, as we might do it ourselves, is incredibly time-consuming and difficult, particularly when complex statistical methods are employed that most of us don't really understand, especially if you get into the subtleties of them. And truthfully, despite evidence, we tend to be experientially oriented, and our experiences condition our judgment and can fool us. Okay. If you think the line on your left is longer than the line on your right, raise your hand. The vertical line. What the hell's the matter with your vision?
They're afraid to make a mistake.
There isn't anyone in the room that doesn't think that the line on the left, the vertical line, is longer than the line on the right. It's okay. There's no right or wrong answer. So if you think that's the case, so indicate. All right. We're getting some response. There's a pulse still there. Now, I'll tell you something. The lines are identical in length. Now look at the lines, and those of you who think that the line on the left or the line on the left looks longer to them than the line on the right, raise your hand. You don't have to be afraid to do this. Okay, a courageous few have volunteered. The point here is that you can be presented with a fact, but retain an illusion. Your interpretation of this figure is likely to stay the same no matter how many times I assure you that these lines are the same. And we don't have time to do this fully, but just for fun, you should write down these cards here. It says, which card or cards must you turn over to verify the rule that if a card shows a vowel on one face, then it has an even number on the other. If you had an audience response system and you were guaranteed this was anonymous and non-trackable, and I asked you for the correct answer, most people, and this has been tested thousands of times, would respond, you must turn over the E and you must turn over the 4. I would then tell you that's wrong, that you have to turn over the E and the 7. And you can draw this and play with it later. And then if I ask, do you think my answer is right or wrong? Only about half the people in the audience would be convinced that my answer was the correct one, even though it is absolutely the correct answer. We tend to retain our biases, even in the face of critical reasonings. Now, this is the way we believe that we think. We think that we listen to reasons, and because we're thinking cognitive human beings, we then come to a judgment. In truth, this has really been studied in great detail by psychologists, educational psychologists, and it does give some credence to what we've all been accused of as surgeons, which is the ready, fire, aim mentality. And in fact, if you go through a reasoning process, these are the processes that occur. The first thing given a situation is that we intuit the answer. We then make a judgment. And then finally, we generate reasoning to support our judgment, regardless of whether it's based on the facts or the material. Let me very briefly describe one of many, many experiments that have demonstrated this. There are a group of graduate students who were subjected to hypnosis, and half of them were given the post-hypnotic suggestion that they would have an adverse reaction to whatever sentence was given to them immediately after their session, and the other half were given a post-hypnotic suggestion that they would be favorably disposed to whatever was read to them after their period of hypnosis. And then they woke all of these people up, got them out of their state, and while it wasn't 100% in either direction, in general, this was what they were told. Wanted to invite the professors in the school to a coffee session where they would meet with the graduate student and discuss their plans for the future and their interests in the future. And what do you think of that? Is that a good idea or is it a bad idea? Well, in a bell-shaped curve, almost all of those students who had been taught that they were going to have an intuitive reaction that was negative said, oh, this is a terrible idea. And those that had the post-hypnotic suggestion to look on this favorably said, what a terrific idea to bring these parties together. And then they said, well, why? And they asked each group why. And each group was able to generate reasons that their judgment of this proposal was correct. And it ranged from things like, well, that student is just seeking favor with the faculty, to, of course, the more positive response that that this is a good way to bring students and faculty together. So intuition in the surgical realm and the things that we've been talking about is basically based on experience. And experience is an historic event. It may be based on your colleagues' events. It may be based on your last case, always has a resounding impact on us. It may be based on a desire for a competitive advantage, as Professor Angelini talked about a little bit earlier. It might be based on your own intrinsic skills, or it might be based on authority figures who have proclaimed one or another approach to be the absolutely correct approach to take. Regardless of how it comes to be, these things generally result in the reason that your opinions today are probably immutable based on the facts that you've been given and the discussions you've been given, because you've made an intuitive judgment about the subject. The hope, of course, is that, and you can draw these interactions yourself, is that even if you follow the process of intuition, judgment, and then reasoning to support your judgment, it's a forum like this where you're exposed to other reasoning that it's actually possible to change some of your intuitive notions, and by doing so to change some of the judgment and reasoning that goes into it. So there is some hope for us for the future, but why are we polarized? It's because we make most of our decisions not by fact, but by intuition. Thanks.
Brilliant.
Thank you. I think we've got about 12 minutes of questions before 12 o'clock, and that's our cut-off time.
Yeah, we've got another presentation.
We've got one more presentation, have we? Are you doing a presentation? So
But ask for some questions.
we better have 2 minutes of questions. How long's your presentation?
My presentation is 5 minutes.
Let's have a couple of minutes of questions, and then we'll do the final presentation.
Can I just ask the audience here, thanks. So this is an audience who are interested in coronary surgery. Let me ask you then, tomorrow the scenario is you find out you need bypass grafts. And you have two options. You can go to surgeons with equally same mortality for this operation, but one who just routinely uses a single mammary artery and the other who routinely uses two mammary arteries. How many of you would preferentially go to the surgeon who does a single mammary artery? Put your hand up. How many of you, given a choice, would go to a surgeon who preferentially and routinely uses two mammary arteries? You see?
So
there's
why,
logic and reasoning.
So the next question is, why are you not using bilateral mammary?
No, I'm not pushing my luck.
Thank you. Got one there.
Hatem al-Bashir from St. James's in Dublin. Question for Mr. Bridgewater. We have seen from your data that BIMA is associated with an excess of early mortality, but better long-term survival. And my question is, when does that better term survival become statistically significant? How many years after operation does the survival curve diverge? And the reason I'm asking is, there is a paper from the Cleveland group by Lytle and Cosgrove, I think published 2010, and it's 20 years outcome of SEMA versus BIMA. And they show that the survival curves start to diverge 10 years after the operation. So taking these two together, one can say that BIMA is associated with an excess of early mortality, and the survival advantage becomes clear 10 years after the operation. And therefore, one can conclude that we should only use it in patients who are expected to survive more than 10 years.
I don't think it's quite as simple as that. I mean, we looked at those survival curves based on surviving the operation and going home from the operation. And when you look at it that way, over that 10-year period, there is a survival advantage. And we didn't really see a need to subdivide it any more than that. We looked at age as an interaction term in that survival thing. There was no interaction between age and survival. So I don't think it's quite as simple as that. I actually asked the same question of Graham, can you tell us when these things do become significant? Do you want to have a comment on that, Graham, from a sort of statistical perspective?
Thank you. We know that somewhere between the procedure date and the discharge dates, there was a spike in the likelihood. So that's why we took the survival from the discharge date rather than procedure dates when we saw this slight drop-off, and the same with the on-off pump as well. That's why we adjusted survival from discharge, because you tend to get the patients who sort of hang on hospital for much longer than the average patient who subsequently die. Once you strip them out of the analysis, then we can't really say. I don't think we can say much more beyond that.
And then looking at the survival, what we kind of intuitively think is that at some point the survival for the bilateral mammaries come significant after 5 years, 10 years, 15 years. And that may be related to the sort of biology of the vein graft and all that kind of stuff. But I remember having a discussion with you about that, and you said you shouldn't look at it that way from the sort of the modelling perspective, the survival modelling perspective. Is that correct?
Yeah, because that's not what that survival model's set up to do. So in that set, it's complete the model as long as we've adjusted for everything, both in the propensity score and in the offsetting of the model. I'm not aware of any other techniques that we could use to start answering questions like that.
Thank you.